Good afternoon, everyone. Thank you for coming. My name is Tom Sinclair. I'm from the Department of Anesthesiology, talking about delirium and what I call the new imperative for treatment. It's coming from a point of view of my own that I've seen that the care of delirium has somewhat been misunderstood or misappreciated or underappreciated, and I'm going to try to impress upon everyone here that this is a very serious illness and something we should be taking care of very seriously. First, before we go any further, I want to really give some kudos to a number of people because I'm going to be talking about not just delirium, but the program we have put into the hospital here that has made our work very successful. The top of the list is Meredith Padilla, who happens to be in Irvine. Meredith, please take a stand and bow. Everybody give her a big hand of applause for the, yeah, thank you. The amount of work she's done, incredible amount of grunt work and groundwork for this, and it's impossible to say how much she has done for this. Don Padley is the nursing coordinator on 6 West who actually introduced me to Meredith. Meredith, by the way, has her PhD in delirium care. Renee Garcia and Patty DeMarco are two of our clinical liaison psychiatrists who've also put in tremendous input into this project that we've been doing. Everybody else here has also done a lot. There's a little star asterisk by Sandy Schluko. I'm going to talk about her as an anonymous nurse later on in the talk, but you'll see why I think she deserves a little recognition as well. Just right now, I'm going to put this out. If you want to take a picture of this, certainly we have it later. If there ever is a concern about delirium and what to do about it, these are our two people who can come and handle the situation and give great advice. And that's their contact number. Essentially, that's their office. It's this great big cell phone. Just as a little introduction. Dad has a heart attack. He gets a stent. He gets a few new meds, maybe puts him on Plavix or something. But he's back home in a few days. He may be a little slow for a while, but he's still Dad. On the other hand, let's say Dad gets delirium. This time, if he develops delirium while he's hospitalized, he may never be able to go home again. He may go to a long-term care facility or a SNF. And I can't tell you the number of people every day who tell me a similar story. The person to whom you're related to is not the same. Your lives are never the same. Dad has dementia, and he's not the same person, and he knows it. He's frightened, he's anxious, depressed, and he can't do anything about it. The physical form is there, but it's not the same person. Dad may be here, but he's not there. And part of this is I can see there's as much gray hair in this room as I have, and you can see at the beginning of the 20th century, there are 3.5 million people over the age of 65. Around 2012, there are 43 million people over 65. And the next 3 or 4 more years, we're going to have another 13 million people over 65. Every day, 10,000 people become eligible for Medicare. This slide, of course, these two essentially could overlap. When we're looking at delirium that can happen in intensive care unit patients, you can see as patients get older, it's almost logarithmic. It goes shooting up to the right-hand corner of the chart. The older you get, the more susceptible you are to delirium. A number of reasons, and we can go into a little bit, but that's just the facts. There's two things I want to add about what we call cognitive dysfunction, and then there's delirium. And cognitive dysfunction, at least for an anesthetic point of view, we see this what we call post-operative cognitive dysfunction, and it refers essentially to some misthinking that happens after surgery. And first of all, in order to diagnose it, you have to be tested preoperatively. So you have to have some neuropsychologic testing done just to get your baseline. And then the spectrum of what is referred to as cognition is diverse. It can do with memory, learning, verbal abilities, perception, et cetera, et cetera. And it's possible to have a decrement in one area and not in another. Whereas delirium's a little different, and we've all seen it. And sort of the gestalt for me is you just can't make contact with that patient. There's a fluctuating mental status, delusions, hallucinations. They can't focus, they can't sustain. The sleep-wake activity cycle is extremely variable and disrupted. And that, 2 or 3 in the morning, they're up roaming the halls. They got to get out of bed. And there's a marked lability in the mood. They may be happy, they may be angry. Next thing you know, they're calm. The next thing, they're crazy again. Post-operative delirium, normally we see this about 1 to 3 days after surgery. But again, we'll have to keep in mind that postoperative delirium is not the only type of delirium that we're going to encounter. We measure it by what's called the CAM assessment method, the confusion assessment method, or the CAM. There's two parts. They have to have part 1 and part 2 that I'm seeing there, and then they can have 3 or 4. So if you have 1 and 2 that's present, and then have the disorganized thinking or altered level of consciousness where they're asleep, they're awake, they're back and forth, that's called a positive CAM, and that means there is delirium that's present. There are a number of ways of measuring delirium, but this happens to be perhaps the most universally used and recognized, and it's, so if you go through the literature, people say, we'll just use the CAM, or the CAM ICU that they use for patients when they're intubated. There is a number of pathophysiologic mechanisms that have been proposed. Nobody really knows. I'm sorry, it's a very busy slide. You can't really see all these things, but this may have to do just with aging. This one is what's called neuroinflammation. Perhaps after a hip fracture or ankle fracture, something of that sort, there's a lot of inflammatory mediators that go passing the blood-brain barrier and set up a lot of dysregulation there within the brain. There's no oxidative stress where the patients are hypoxic and hypovolemic, perhaps hypotensive. That may also lead to some sort of oxygen deprivation to the brain that may lead to neuronal apoptosis. There's sort of neuro dysregulation that may be going on, and there's other things where just disruption of the circadian rhythms, where certainly in ICUs where patients just don't sleep, it's a very well-known risk factor for leading to delirium, is that patients aren't getting enough adequate and proper sleep, and sleeping pills don't work. Mind over matter. This is a hidden epidemic, and this is what I'm going to be focusing on. Up to 40% of patients who develop post-operative, now again, I'm talking about post-operative here, but the thing is, if you go through the literature, it's the same, not just for post-operative, it can be for sepsis-induced delirium, ICU delirium. If you have delirium, the long-term effects are there, and they're serious and they're devastating. These people will never go back to the preoperative baseline. Even with post-operative cognitive dysfunction, where there's a little disorganized thinking, it's a little bit more than I can't find my car keys and where are my glasses, but they can't remember their meds, they forget their children's names, they can't remember directions. It's a serious thing. You can take them out of the workforce. Great majority will come back to where they were or where they would have been had there been some sort of cognitive decline going on. All the same, it is still has a tremendous impact. The bottom line is we need to start relooking at delirium, post-operative cognitive function in a whole different way. Okay, to lead into this is my own personal editorial I sent to our group. We spend a lot of time working up patients preoperatively for cardiac status, and up to 9% of patients will get either a treadmill, they may get a nucleotide study, they may get angiography, all to prevent any kind of cardiac event that may happen in the surgery. And if we do see someone who is at risk for cardiac disease, we adjust the anesthetic as well as we can, and then we send these patients to tele, wherever, to ensure that they remain stable post-operatively. What is the risk? Now, just diverting just a little bit to give you a little background on this. When your patient is having high-risk surgery, okay, and if you have all of these, intrathoracic or intraperitoneal, or some sort of intravascular or a vascular surgery in the belly or chest, and they have ischemic heart disease, and they have history of CHF, and they've got some cerebral vascular disease, and they're diabetic, and their creatinine have some degree of renal insufficiency, the risk of a major cardiac event is around 11%. We'll be seeing it with delirium. Busy slide here, lots of data. Length of ICU, if it's either present or absent. Length of the stay, if it's present, essentially double. Length of hospital stay, essentially double. Cost, and this is in 2009 when this study came out, so these dollars are probably 10 to 12 years old. 50 grand versus 31,000 per day, total. That's around $2,200 per day extra that you're spending. Post-discharge institutionalization. You're going to SNF or long-term care. 1 out of 3 of these patients are going, versus 1% is going to go home. Mortality. I'll talk about this a little bit more. Here's your cardiac stuff. 6-month mortality, 20%. Now again, is it just due to delirium or other things? Maybe, maybe not. I'll talk about that in a moment. But all the same, it's serious. Delirium, if you have delirium, you're at risk for not surviving too much longer. Same thing here. This is another study that came out in 2015 with over 500 patients. If you have no complications whatsoever, come and get your surgery, you're home in about 5 days. If you have some complication, maybe some mild CHF, maybe a little renal insufficiency, maybe you get a little fluid overloaded, you've added a couple of days to your stay. If you're just delirious post-op, you've added a day. But if you have delirium and complications, essentially you've doubled your length of stay. You're staying there much, much longer. And the chances are you're going to, about 75%, you're going to a SNF. You're not going home. 30-day readmission, 30%. Of course, for the hospital, that's very important. If you come back within 30 days with the same diagnosis, it's on the house. Trajectory here, what happens? So this is a recent study again, came out, that patients who had delirium were had less functional recovery, like activities of daily living, associated with persistent and clinically meaningful impairment of functional recovery up to 1.5 years later. So a huge impact. So what can we do that is use of multifactorial preventive interventions? This is from them, of course, I'm quoting them. At high risk for delirium and tailored transitional care planning may help to maximize the functional benefits of elective surgery. Now, again, same sort of thing. This, by the way, in this instance, they said 3.7% develop postoperative delirium. This is the lowest number quoted anywhere. And remember, go back to that 11% major cardiac event with 6 different significant cardiac risk factors. This is, of course, all comers. If you do get postoperative delirium, it's much higher in patients who had pre-existing mild cognitive impairment, this MCI, or dementia compared with none. In other words, 8.5 versus 2%. It was, again, the frequency of MCI dementia at the first postoperative evaluation was higher in patients who had delirium compared to those who did not, versus 33% versus 9%. In other words, if you come in with some degree of cognitive impairment, 33% chance of having delirium. This is a slide that disturbs me. Similar sort of stuff, big population, 1,600 patients roughly. Patients come in, this analysis one, preoperative cognitive status, normal cognition, 44% of them, 2.6% of these patients had some post-op delirium. The patients with dementia, 8.7% post-op delirium. Now, if we go to this second analysis, these are people who walked into the hospital normal brain function. They're doing quite fine. These who had no delirium post-operatively, they still come out with some dementia, at 9%. Now, they could be catching them on their sort of normal decline in cognitive function as they're aging, but those who had normal cognitive function and they get post-op delirium, this group of people here, 33% come out with dementia. This is serious stuff. So the dementia leading to delirium leads to permanent decline. I've mentioned mortality. Several studies suggest that delirium per se by itself is a risk factor for mortality, and they're looking at 6 months. But this review questioned that, says perhaps normal delirium is so enmeshed with other variables, say heart disease and renal disease, cerebral vascular disease, it's hard to sort of parse it out and say this is all due to just because this patient had delirium. However, if you have delirium, there is a 4-fold increase in mortality at 6 months. This is called a whisker diagram. That to the left is decreased mortality, that to the right is increased mortality. All these little dots are the means for these different studies. This big back ace of diamonds here is the 4.4 incidence or odds against having increased mortality right here. So in other words, mortality it's dissociated with delirium, and it's significant. Now, which leads to, this just came out last month in the Anesthesia and Analgesia Journal, and they're looking at informed consent. And today, we have not been talking about this with our patients. In other words, if I see a patient and they say, well, what are my problems? I say, well, you got a 1 in 1,000 chance I might damage your teeth, you're gonna have a sore throat, you might have some nausea. They're far lower risk of having cardiac disease or some cardiac event. If you have no risk factors, it's about 0.3% for a cardiac event. So that's 3 per 10,000. Stroke is about, 3 per 1,000. Stroke is about 3 to 8 out of 10,000 for having a stroke. I mentioned these things as part of the informed consent. But what I don't tell them is if you're over 65, you have a 10 to 15% chance of coming out with some degree of cognitive function, if not dementia that is lasting and permanent. It mentions up here with thresholds of foreseeability, of course that makes sense. And materiality with new deficits. And I had to look this up. We've all heard the expression material witness. That just means, are you germane to the process? And would your information then make a difference in the decision making of the individual making the decision? So that's what materiality with it. So to ensure that consent for surgery is properly informed, risks of both cognitive function and alternate management strategies. This is from this editorial. Both the people that wrote it, by the way, are attorneys and they're doctors, so they're half good. Sorry, jokes kind of bad. I'm sorry. But what they're really saying is the decision has to be made before we see these patients in the pre-op area. It's not my time to sit there and say, oh, by the way, if you have your surgery, you could be demented. Is it really worth having your cancer removed? I mean, obviously there are some hard choices that could be made, but the patient, at least particularly in this day and age, patients have the right to know this stuff. So those of you in the community, I really ask you to say, bring this up with your patient. We're happy to talk to them about it, and their surgeon particularly should talk to them about it. Okay, this is just sort of a similar sort of thing. This was for hip and knee replacements. The average age of these patients is in the early 70s. 24% of them screened positive for some mild cognitive impairment. Now they're using what's called mild cognitive impairment. They're using what's called a mini-cog. I'll mention that a little bit later. Dr. Schenkel here has kind of shown me that mini-cog's not the best test for screening, but it's something they used. But what happened, those patients who showed some degree of cognitive impairment, 2/3 versus 1/3 went to a place other than home. So it's twice the chance of not going home. Rehab facility, 20% of those got delirium versus 7%. The thing is with this, the 7% is the patients who had normal cognitive function. So 20% here of these patients are coming out with some degree of delirium, and then of course there's that risk of having permanent mental impairment afterwards. All right, here's another vignette here I'd like to put up. This is an 80-year-old patient who's admitted for a repair of a greater trochanter fracture. Her family tells that after all her other surgeries, she's been violent and combative, agitated. She's very foul-mouthed, tells the family how much she hates them, she wants to kill them. This, of course, is very disconcerting to the family. So my colleague, Dr. Jake Cornett, says, okay, piece of cake. And what this is, it's not any kind of situation, any sort of specific formula that we follow or anything. It's just the culture of awareness. He says, all right, I'm going to approach this in a different manner, and I'm going to treat this lady with as gently as I can with my anesthetic. So use a little propofol, we're all familiar. Gets her just sedated enough to put in the spinal, and that's it. They get her set up there in the operating table. He wraps her head up in some warm towels, which I actually used yesterday for a procedure, and a 96-year-old worked, I guess. Played some big band music from the 40s, and she stayed the same, got back to the recovery room, normal preoperative self. Family says we've never seen her come out of this after surgery after that. Kudos to Jake, but again, it has to do with the culture of awareness that we're creating here. It can be avoided, though. That's my whole point. Delirium can be avoided. There's risk factors to be aware of. There's certainly for delirium, as I mentioned, dementia, depression, greater age 70. Preoperative use of narcotics of benzodiazepines. I'm going to focus on this a little bit later. These are nasty. They're just nasty. That's all I can say. I'm using sort of a vernacular for it, but stay away from it. Alcohol, of course, is going to set you up for a little bit more issues. Previous history of delirium, as our previous patient I just mentioned, a number of others. Cognitive decline, same thing. This is sort of a mnemonic, and I think I'm going to just run through these, but it's a number of drugs. So we'll go through it. Of course, you can see it spells delirium. And there are a number of mnemonics out there. If you go through the delirium literature, you're going to come across all these mnemonics. Consider if you see a patient. Now, I mentioned postoperative delirium. However, if you have a patient, it's like day 2, day 3 post-op, and they're beginning to look a little crazy, you do have to consider other things besides just the response or the rebound off of delirium, off of the anesthetic and surgery, because they could be infected, but there's certain drugs that maybe you've been using that are causing that. Make sure that they're dehydrated, make sure your sodium's normal, thyroid's normal. Could they be withdrawing? Could this be an alcohol withdrawal? We can see right there. Infection, of course, urinary tract, respiratory tract, and soft tissue infections. Of course, we all hear of urosepsis. It seems to be a common one. Reduced sensory input. Make sure that they got their hearing aids in. Make sure that they got their glasses back. Visual impairment is perhaps the biggest, which is I found fascinating to read that. Whereas hearing aids, I'd really like to have there in the operating room with the patient. I can go, Mr. Jones, you're just waking up, surgery's done, and it does appear to have an immediate impact as opposed to being lost. And then, of course, you have to think something going on in the head. Maybe this is not delirium, but some other neurologic process that's going on. Urinary and fecal disorders. My wife used to be the DON at a nursing home, and she said they kept a BM book, and that was very important. And then I mentioned the cystocerebral syndrome for urinary retention, and she said she hadn't heard of that, but lo and behold, if you can't pee after a while, it's going to drive you crazy. Of course, you have to think, are your heart and lungs, are you perfusing your brain? And there's a number of miscellaneous things that go on. Certain drugs, various over-the-counter agents that can cause delirium. But I like the one, of course, there's some other unusual ones, like the serotonin syndrome, if they're on the serotonin inhibitor, SSRIs, receptor inhibitors, neuroleptic malignant syndrome. I don't know an anesthesiologist who's ever seen this, but it does happen, which this is similar to a malignant hyperthermia, and it's associated with use of antipsychotics, anticholinergic states. You know, if mad as a hat, red as a beet, crazy as a hatter, that one. But my favorite was his heavy metals. And of course, this is one I'm very curious about. Is just be aware of manganese poisoning. I just caught my eye. I've never heard of it. I barely know what manganese is. The other thing is sleep apnea. There's a good review on this that suggests that sleep apnea can be a cause of delirium postoperatively. And so if you have a patient, put their CPAP mask on and make sure they use it. And what can be done? Okay. Now I've kind of given you a background of what can be done and what happens with delirium. I want to go on and show you there is a number of things that can help out. First of all, there are a number of screening tools that can help you depict or find out who is at risk for delirium. And this came from an editorial from a British journal, I believe. Preoperative medicine. And essentially he's saying that this should be part of your workup. For anyone, say 60, 65, you get an electrocardiogram, you're checking their hemoglobin A1C, and they should get precognitive testing as well. There are a number of cognitive assessment tests. And as you can see, I know very little about them other than that they are available, and that's for the experts to use. But this is the one Dr. Schenkel just gave me, pointing out that what they use here is the MCI screen, the sensitivity of 86 to 96%, the specificity 95 to 100%. I mentioned the mini-cog just a few slides back, 50% sensitivity. So they may have lost or overlooked a number of patients in that group, and it's not necessarily that specific. The bottom line is there's some ways that we can test for it. We have right here local resources for our vital brain aging programs right here in this building. Is that right? Yeah, it's right here in this building. Yeah. And our screening coordinator is Celine Keeble, and it's her email, and that's her phone number. Please, if you have a patient with any kind of sort of concerns, these are the people to go to. We used a thing for the hospital and surgical programs called the AWOL tool. It was originally developed for medical patients. There's only one study that looked at those, and Meredith Padilla, whom I mentioned earlier, was involved with that. We're using it for stratification. And if you're over 80, you get a point. If you're unable to spell world backwards, you get a point. I know you're all doing that right now. And everybody laughs when I bring that up. If you can do it in Spanish, Ode any Ulumi, you're okay. And you have to be oriented to 5 places, just city, state, county, the hospital, and the floor. And my gosh, I think sometimes I'm on 4 West or 3 East, I don't know. It's tough, but you have to do it. And then the 1 point for illness, where it's an ASA scoring. Essentially, this is patients who are ASA 3, which is some degree of impairment with a number of systemic diseases. Delirium rates based on the AWOL score. If you're 0, your risk is around 2%. We found 3%. Risk of 1, you're around 4%. But we figured significant here of around 2, that's 14%. We're half that with our data. However, when you're at AWOL 3, AWOL 4, this is 1 out of 5 times. Odds are 5 to 1 now on this one. When you're playing the horses, that's not a bad bet to get it. When this is now 64% of our ASA 4. We're 20% on this one, and I'm wondering, and I'll talk about this later, but I'm wondering if it's because we pay so much more attention to these patients who are the ASA 4s, AWOL 4s. Key things, Intra-Op Care. What are we doing? We avoid benzodiazepines, and I mentioned that about chronic benzodiazepine use, or I think probably even worse is acute benzodiazepine use. We avoid excessive depth of anesthesia. We use a thing called the BIS monitor, which essentially is a one-channel EEG that gives us a range of the depth of sleep or of hypnosis. We keep it within a certain range so that we know they're asleep. 1, there's no awareness, but 2, we're preventing getting isoelectric. And I have had patients, elderly patients, where I almost have no vapor on at all, and they're barely above, they have barely any electrical activity in the forebrain there. So so we have to be very, otherwise I could see with what my partners, one study looked at just the end-tidal gas that's in the lung, and these patients do far worse than those with this BIS monitor. We try to maximize the use of regional anesthesia if it's an arm block or leg block or a spinal, minimize their opiates. Ideally with our regional techniques we can minimize this, and avoid any medications with increased risk of delirium, which is the Beers list. I'll mention that in just a moment too. Post-op care, I think that's the biggest and most important thing we do, because they're in the hospital 1, 3, 4, 5, 6 days, maybe longer. This is where Meredith's work teaching the nurses, 1, how to do the CAM assessment first, and then all these principles of post-op care. This is sort of came out, what's called the Hospital Elder Life Program. And they really essentially showed that the program successfully prevents cognitive and functional decline in at-risk older patients. These again, principles are based on multiple meds. In other words, minimizing the meds that the patients are getting, making sure they're well hydrated. Immobilization is bad. We can get them out of bed as quickly, as rapidly as possible. My lady yesterday who had her femur fractured, she's now out of bed. She's walking, well, with help. And I mentioned this to the orthopod yesterday. I said, you guys are cruel. He says, yeah, we are, but we're getting them out of bed. We're making them move. If you break your hip in the morning, you're moving in the afternoon. She couldn't move because they had her in a knee brace. But if you get your hip fixed in the morning, you're walking that afternoon, maybe slowly, but it's very important. Sensory impairment, make sure we'll go into it, and sleep disturbance. This is Meredith's sort of thing. Again, this is sort of the principles of taking care of floor care, but there's a whole variety of stuff. And I'm just you can look at it, but cognitive stimulation, patients are in the room, encourage family, encourage friends. If you have a friend or something in the hospital, come visit. It helps to reorient them. And then no parties late at night. Mom, Dad, we're going to leave you now. It's bedtime. It's 9:30. See you tomorrow morning. Orientation. We try to have big clocks in there. Ideally, if patient can have a nice view of the ocean, or if not, they get a view of the pipes on the roof. Verbally reorienting the patient. Dr. Sinclair, it's Friday. It's 2 in the afternoon, and you just had your knee replaced. You're at Hoag Hospital, blah, blah, blah. You do that throughout the day, just as constant reassurance and reaffirming where they are. Early mobilization, limited use of restraints. Our psychiatrists hate, loathe, detest that poses the restraints. They say it's the worst thing. Imagine if you're feeling crummy and you're tied to the bed. That sucks. Just, again, back to the vernacular here, it's not great. And then making sure they have their hearing and visual aids available. Make sure they get their glasses so they can see and reorient. This is what one of my colleagues called bag and drag. This is the ICU. Our ICU docs, the intensivists, are very big on mobilization. And yep, she is intubated. She is on a ventilator here. And she is walking. That's how serious they take mobilization here. Getting out of bed. Of all the things that may, at least ICU, that may minimize delirium risk, it's this, mobilization, getting up. Hard to imagine, hard to see. And of course, our ICU we have a little different programs going. Their prevalence of delirium in the ICU is 11%. National average is 32%. So walking with a vent seems to be very, very helpful. Sleep. This, I think, also is very important. If you talk to anybody who says, I haven't slept in a week because kids or the neighbor's dog or blah, 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 I'm going to go crazy. That's the quote. How many times have you heard, I'm going to go crazy if I don't get a good night's sleep? Same thing here. Just minimize the nighttime noise. I have a little story. The nurse that I gave a little ascaris up at the beginning. It's, 2 in the morning now? She puts her headlamp on. Little things you see. Then she goes into the room and uses that. Doesn't turn on the lights. Checks the pumps. Make sure everything's working just fine. Her patient remains sleeping. Several nights later, again, this has to do more with the culture of awareness, what we're doing. She's floating to another floor and sees that a patient is on one of the meds on the beers list, which I'll show you in just a moment. And she calls the pharmacy, which now the program allows for a nurse to call the pharmacy and say, this patient is on a drug we think may be deliriogenic. Will you call the hospitalist or the attending physician and suggest something else? She does that. Patient does fine. This is, like I say, kudos to Sandy for that. But again, it's that sort of, there's no scheduled way of doing this stuff. It's just being aware of what we can do to minimize the impact of the hospitalization. And again, here we are, the beers list. There are a number of them. Drugs with anticholinergic properties. There's the whole thing called the cholinergic hypothesis for delirium and dementia, where acetylcholine is one of the major transmitters there in the brain. We block that, then it interferes with normal brain functioning. So the tricyclics, antihistamines, that's where there's some question about patients on long-term Benadryl, for instance, may have some increased risk of dementia. H2 blockers for acids, stomach acid, olanzapine peroxide. Okay, where's the other? Okay, this old one, meperidine, Demerol, bad news, and the sedative hypnotics, benzodiazepines. This is Xanax, Valium, Ativan, Versed, and then the others. This is Ambien. And then if you started 5 new medicines over at the same time. And you can imagine if you got 5 new medicines, what it would do to an elderly liver and metabolism with your CYP, whole metabolic enzyme work, what that's just going to overload it. Here's the big one. And our psychiatrist, Renee Garcia, keeps telling me, this is totally anathema. This is lorazepam or Ativan. And there's not that much of a chance. You get up to 10 milligrams, you're 80% chance of getting delirious. So you're starting right around here, 3 or 4, 70%. So where we're using Ativan to treat delirium, all we've done is made it worse. And if you talk to, say, Don Padley or Six West, she said what happens by the time the patients get it, they will get it and they will fall asleep. And so they're asleep by 3 or 4 in the morning, and they'll sleep to 8 or 9 next morning. So their whole sleep-wake cycle is destroyed as well. So again, the whole idea is to avoid this, if at all possible. I do have one little sidebar to that. There was an article recently that came out and looked at Ativan and Haldol in end-of-life patients with delirium, and they found that Ativan and Haldol together seemed to help some calming of those delirious symptoms. However, their company editorial said, this is for end-of-life patients. Now, this is people in their last days of life. This is not for ICU. Pain and post-operative delirium, cognitive dysfunction, pain hurts and it will drive you crazy. But, excuse me, I'm ahead of myself. But it does remain a risk factor for delirium. But again, the AGS recommends that we use regional techniques to augment post-op pain control. Here's the key thing, that higher pain levels at rest are associated with delirium. Pain with movement and maximum pain were not associated with delirium. This makes intuitive sense to me, that if I'd had my knee replaced and I'd go walking, dang, that hurts. But I can deal with that because I'm not surprised that it's hurting. If, on the other hand, I'm lying in bed and I want to sleep and all I get is this signal from my knee saying, hey, it hurts, that's going to make me crazy. I was just talking to one surgeon before I came over, same thing. He had some injury and he said he couldn't sleep, he thought he was going to go crazy. Then the type of opioid and cumulative opioid dose were not associated with increased risk of delirium. So that's the type. And I think my next slide. Yeah. But Demerol, bad news. But it doesn't really, so far to date, it doesn't matter which one of the narcotics you use. Morphine, fentanyl, or Dilaudid doesn't really seem to matter just as long as the pain's controlled. Again, this is a double-edged sword. Narcotics cause delirium. Pain causes delirium. It's a fine balancing act. And we do our best. What can I say? That IV or epidural techniques do not influence cognitive function differently, which kind of belittles the impact of having epidural, of regional anesthetic, but all the same. We're still working on it. Sorry. Yeah, okay. Now, going through a number of these different approaches to take care of it, but back to the hospital elder life program that I mentioned earlier. This program was done on medical patients, and they essentially applied all these non-pharmacological techniques, reorienting, encouraging physiologic sleep, making sure they're up and mobilized. It's almost cut their length of stay in half just by this non-pharmacological way of taking care of patients. Seen in rates of death, 23% versus 9%. Obviously, these are sick patients, but 23% mortality rate with these patients who had delirium. ICU transfers, the hospital's going to like that one. 30-day readmissions, again, 31 versus 5%. Very, very impressive results just with this whole sort of non-pharmacological way of approaching delirium and preventing it. It's not treating it, it's just preventing it. This is another study out of Taiwan. They looked, again, just putting this as sort of a preview to what's coming up. only looked at post-operative ward care, did not address pre-op or intra-op care, whereas these patients weren't selected for any sort of ward care. They did what's called the modified help, which is that hospital elder life program, and I still couldn't figure out what they did to modify it. But their length of stay was reduced by 2 days. And yeah, that it helped get patients out of the hospital. Now, we decided to, this was a little over a year ago, we said, what can we do? So we took all of the existing knowledge and evidence and said, let's apply a program. We did not wait to get a baseline. Unfortunately, for a big fancy study, that wasn't our goal. It was just to start treating patients and making sure we can help out. And so we did like 35 patients. We got 2 patients with delirium, 39. Or so, I had 1 patient out of 35. I think obviously I had to discard some of these. Anyway, 2.9%. Well, we were very happy with that. And so we took then abdominal and thoracic patients, and those who had an AWOL score greater than 2, that means that they're at risk for delirium. And again, no one's really looked at this as post-operative, but for a delirium rate of 14% is what was predicted. And we used the non-pharmacological principles of care similar to the hospital elder life program. And then we went on to do 3 East, where all our orthopedic trauma is. What orthopedic trauma, again, is the broken hips, legs, et cetera, plus some I&D of joints and that sort of thing. Prevention here starts in our pre-op area. These patients are screened with the AWOL. It takes about literally less than a minute, you know. Can you spell world backward for me? And you're 80, okay, no, yes. How ill are we? That's a nurse can just look immediately and tell me, Dr. Sinclair, where are you? I'm not sure yet, okay. Then we do, once the anesthesiologist sees, oh, this is an AWOL 2 or greater, or even if this is some sort of intuitive feel, you know, I'm going to this patient's 91 years old, I don't even need to know. I'm going to be anesthesia light, like my partner, Dr. Cornett, did, and we just try to minimize the impact we have. And then the subsequent ward care, again, what did we find? We have 246 patients. This is literally data as of Wednesday that I finally got. I apologize for the ragged appearance of the slide. But we had 61 patients, AWOL is 0, 2 were positive, which I find little. In other words, they came here normal as far as we could tell. Now again, this is a crude tool, so it's very possible there was some degree of mild cognitive impairment that could not be picked up with the AWOL, but so they come up with a little delirium, and these people could be at risk for some degree of cognitive impairment afterwards. Our ones, hey, there's better to come in and not know where you are and come out with a rate of 0. I can't explain that totally. AWOL 2, we 46 patients of these. Now, we have a 6.5%. The original study looked at 14, had 14%. And this is where we had 31 patients, AWOL of 3. The rate of 1 out of 3 of these patients had delirium. I'm a little upset by that, but just because there were some other things that go on, I think we have a lot of improvement. We had 20 patients with an AWOL of 4. All of these are over, I think our average age is 81 or 82 for these AWOL 4 patients, and the rate is 20%. Again, the original rate, if you can remember, was 64% of those. Our overall delirium rate is 8.1, which I'll show you is very, very good. Our orthopedic rate is 11.9, which is very good. If you just take away the orthopedic, we're 5.1, which is the lowest reported in the literature. Yeah, here we are, just a little tidbit. And average age of the CAM positive patient is 81 years. In other words, I showed that early in the talked about aging population going up, and also the incidence of delirium going up. This number, of course, fits. The older you get, the more susceptible you are to having some degree of delirium. 4 of our 9 CAM positive, this is the last group. 2 of those are 78 years old, received 5 milligrams, of Versed. The others, 81 and 82, received 2 milligrams. I have talked to my anesthesia group about that. In my mind, that was never mind. Comparable, just so you get an idea of what we're doing, this Mayo Clinic said 3.7%, we had 5.6. But they don't really go into details about it, but that's the lowest number. I said we had the lowest. They're a little bit lower than us. This is another big one that I just mentioned previously. Their post-operative delirium rate was 6.6, but their control group was 15%, which is what you'll normally see. This 15% compares to other studies, which are down in here in the anesthesia literature, and it goes anywhere from 15% to 40%. So we are doing very well if you're having non-orthopedic surgery. But even if you have orthopedic surgery, this was the intervention group, was 1 in 3 chance had delirium after surgery versus 50% in the non-intervention group. Another one, this is showed that the so-called light anesthetic group, 19% versus 40%. So 40% chance of delirium in this group. And then another 30-some% rate of post-operative delirium, whereas they took out 23% of these patients because they already were suffering from delirium. Our delirium rate, again, is 11.9%. So just to brag about us a little bit, so far there has been no published studies that involve preoperative screening where you target the patient for specialized care, and these patients then receive an adjusted anesthetic, and then they get followed by specialized post-op care. The studies, there's some studies that just look at what I've quoted, either look at the impact of the anesthesia, others look at what happens on the floor. For instance, these only study medical patients or post-op care, but not measuring what happens intra-op. We are providing admission to discharge delirium prevention care. Tell your friends. This is what we're doing, and we're getting better at it. So, last thing. Dad's home now. Mom's overwhelmed. She's been slowing down anyway, and it's difficult for her to care for Dad, and it's difficult to run the house. He paid the bills, he helped with the shopping, did all the driving. It's too unsafe for him to drive. He's incapable of handling finances. Your parents are now your children. And delirium is a devastating disease. It's not just the family, not just the patient, it's also the family. It is imperative we approach this illness with the same intensity we approach all the serious illnesses that I mentioned earlier. Any questions? I am done here. All right, thank you very much.